Okay, and here we go. Here we come.
Welcome, welcome. As you come into the room, we'll get started in just a minute. We have a lot of attendees today, so we'll let people come into the space. We're really excited to be here. Good morning, Julie. Welcome to everyone coming into the room. We're just going to give it a minute. We have a lot of folks registered for today's webinar, so we'll get started in just a minute. Good morning to all. I think what I'll do is go ahead and get started with the introduction slides. And by the time our presenters, Carol and Hanir, come on board, hopefully everybody's in the room. So welcome to the Peer Recovery Center of Excellence webinar on the intersection of prevention and recovery. Today, we're going to spend some time with Carol Oliver and Hanir Hernandez. Next slide, please. Today's webinar, The Intersection of Prevention and Recovery, is a collaborative webinar series between the Peer Recovery Center of Excellence, the Great Lakes Prevention Technology Transfer Center, and the Prevention Technology Transfer Center Network. Funding for this initiative was made possible by SAMHSA. The views within this webinar do not necessarily reflect the official policies of the Department of Health and Human Services. This is just the structure for the Peer Recovery Center of Excellence. And so we have a team that focuses on clinical integration of peer recovery support workers, building and strengthening the capacity of recovery community organizations, enhancing the professionalization of the peer recovery support workforce, and providing evidence-based practice toolkits, resource information on diverse stakeholders. And this is our language matters slide. So if we want addiction destigmatized, we need a language that's unified. And so we don't refer to people as their disease or diagnosis, but we use person-first language in everything we do. And this is where I'm going to hand it over to Carol and Hanir. Welcome. Thank you for being here. Oh, you're muted, Carol.
Sorry about that. Hi, my name is Carol Oliver, and I'm very excited to be here with Hanir. I worked in the field of substance misuse prevention since the 1990s and have done a lot of training and technical assistance and have been fortunate to work on projects having to do with the intersection of prevention and recovery. So this is one of my favorite topics, and I was thrilled to be asked to be a part of it. And as we introduce ourselves too, I'm going to turn it over to Hanir. Please feel free in the chat just to tell us what your name is and where you live. Where are you in the country? And so while people are doing that, I'm gonna have Hanir, you introduce yourself.
Thank you, Carol. Good morning, everybody. Buenos dias. My name is Hanir Hernandez, and I am originally from Puerto Rico. I live in Massachusetts. I've worked in the field of health and human services for 33 and a half years now, with a focus on prevention, intervention, treatment, and recovery supports. I am a certified prevention specialist as well as a clinical person in this field. I've worked in residential settings, outpatient settings, that sort of thing, and with a primary focus on addressing issues of disparities and building equity in communities. I've worked all over the country. The only state that I haven't worked in is the state of Alaska. So I am really happy to be here with you. I have a lot of letters after my name. As you saw from that first slide, I have a PhD, but I also want you to know that I have a GED, and my GED I got in prison. It was more difficult to get that GED in prison than to get a PhD out here. I am a person in long-term recovery, and what that means for me is that I have not used a drug, including alcohol, for the last 34.5 years. What that enables me to do is to be a productive member of my family, my community, and to do this type of work and be present. So I look forward to hearing from you in the chat through your questions and contributions, and not just today, but during the second session that we have as well. Good morning, and once again, thank you for joining.
And
That's
Carol,
great.
I'm
And
just,
Hanair, you have some, oops, sorry.
oh, I was just going to jump back in and let people know that today we're going to be using the chat to interact, to ask questions, to make comments about maybe what the speakers are talking about. And then we're going to reserve the Q&A function that you can reach by hovering over the bottom of your screen for any technical questions. So if you don't have audio or you can't hear a speaker or something's happening, please put any technical questions into the Q&A, and we'll use the chat to communicate with each other. Thank you, Carol.
That's great. And Hanair, I was just going to tell you, you have some shout outs from people thanking you for sharing your story.
Thank you.
All right. And that sort of brings us to learning about you all. Oops. Sorry, I'm just having a slight problem. So what we're going to do is we kind of get a sense of your experience and get a sense on the call. I did see while people were scrolling through the chat, we seem to have people from both recovery and prevention from all over the country. And so what we'll do is bring up the poll. And this is going to give us just a sense of what your experience is. And I think I need to stop sharing.
I'll see if Cindy, are you able to put up the poll?
I'm sorry, I was answering questions. Here we go. Apologize for that.
Excellent.
Okay.
Wonderful. Our collective experience. So just choose one, and I think we've covered all our bases. So please tell us. So I have experience working in recovery. I have experience working in prevention. I'm like Hanair, and I have experience working in both. Or I'm here to listen and learn more. So just click the answer that seems to correspond with your experience, and we'll get a sense. We have a lot of people from across the country that are on, so it's always really interesting to find out the different experiences that people have.
You want me to keep? We've got almost all the votes in. I'm going to go ahead and close it.
All right.
Okay.
Excellent. Excellent.
And
That's great.
Let me share the results real quick with everyone. And
so we've got about 15% recovery, 29%. We've got a fair amount who have both, and a fair amount of some people who are just there to listen, which is great. So this training is really meant to work for all of these audience, whether you have experience in recovery, you have experience in prevention, or you're just sort of curious about both. Let's close that. Thanks everybody for participating. That was incredibly helpful. All right, and we'll move on to the next slide. So this is what our roadmap for today is. So one of the things we're going to do is begin with a conversation to get us started. So I have this quick story. I worked in a sort of full continuum substance misuse treatment organization. And I was the director of prevention. And we had this outpatient facility, and that's where my office was. And there was a lot of differences between the prevention staff and the other staff. And one of the things that we had in common is everybody had lunch together. And through that lunch experience, people had a lot of conversations about what they were doing, how they were doing it. People asked each other questions. And what occurred to me was the way you get collaboration, the way you understand, is by having dialogue and having conversations. And so this training is really about that. It's about you all learning. It's about us having a dialogue and question. And so that's where we're going to begin. We're going to first give some basic foundational information. So depending on where you're coming from, whether you have prevention or recovery or neither, we're going to give some foundational information on prevention. We're going to give some foundational information about recovery. We're going to talk about recovery capital, which is a really important concept. And that's the first of the webinars. So the real fun, fantastic things are also happening on the 29th, and that's really, that webinar is where we're going to explore how do we really collaborate and what does collaboration look like. And so that is a really exciting session as well. So that's what our roadmap is for today. Okay, and I'm going to hand it over to Haner, who's going to take us through some guidelines.
Thank you, Carol, once again. And it's from my end, it's good to see people who are working on both prevention and recovery issues. Let us not forget that by doing so, we are also bringing down silos, and silos have impacted our communities in very significant ways because our folks are holistic beings, not fragments of one thing here and one thing there. So I'm really happy for that. If you could put in the chat feature there, what guidelines do you need to make this space safe for discussing the issues that we're going to discuss moving forward? We always add these pieces on respect. We know that being open is connected to being respectful, right? Not all of us share the same views. In relationship to confidentiality, I always tell people, share the message and not the messenger, right? There are people already in the chat who are saying, I'm in recovery, I am this, I am that, I have this experience. And that is awesome, but they shared it with us in this room, right? You can share my story all you want. You have permission from me to do that. The stretch rule, if you're one of those people who talks a great deal, I do that a lot because I'm a trainer and talker. Stretch in the direction of allowing other people to chime in. And if you're one of those people who doesn't talk a great deal, please chime in, because what you have to say or are thinking is really important. We should always assume that other people have good intentions in terms of what they're doing. We work in this field for a reason, right? We want to help, that sort of thing. And let's be strength-based. There was some talk about what that means, not just in language, right? But in our approach, in our questions. It's important to lead with strength and not to either put people down, those sorts of things. Next slide, please. And thank you for all of you who've already come into the chat talking about respect and those sorts of things. In terms of some general suggestions here, come ready to participate fully and critically online. I mean, some of the stuff that we're going to talk about, for some people might be challenging. For others, it's like, oh, wow, this is about time that we're talking about these things. But it's important to come prepared. Do your best to engage with the technology and make sure that you attend to your needs, right? We've been in this COVID space for over a year. And here we are online, right? And so we need to take care of ourselves and do the best with technology. We know that it's been challenging for a lot of people, particularly those who didn't have a lot of experience online. I think about marginalized communities and their experiences with technologies. Next slide, please. And then chat etiquette, just really briefly here, you know, ask questions. You've already been doing that, making comments. That's awesome, right? And so we have that Q&A section and we have the chat. Use those, right? Ask questions, make contributions. Keep private conversations to a minimum and avoid distractions, right? Because when we do that, someone might be saying something that could be important to our learning process. We expect respectful professional etiquette over the chat, right? If you wouldn't say something to someone face to face, we shouldn't, you know, say it in the chat. And most of us have stories and stories and stories about what has transpired over the last year and a half. So we want to minimize that, eliminate that from this process. So those are some of the things that we think will make this webinar and the next one productive. Thank you very much. I'm going to give it back to Carol. Carol, you're muted.
Sorry, I'm going to have to work on that. So this is what we're hoping our destination is. This is what we're hoping that you are going to be able to walk away with, which is really being able to describe the intersection between prevention and recovery approaches, understand common terms that are used in prevention and recovery, and to apply a more holistic approach to sort of, you know, the gamut of within behavioral health from prevention, treatment, and recovery, and sort of look at it from a holistic perspective as well. So one of the things that we want to do is frame the day. And, you know, I had the experience of a couple of years ago working on a training with people in recovery, and I was working with people who were in prevention. And I learned a lot from that process. And one of the things I learned was that you have to have some hard conversations and just be able to be open around understanding where people are coming from in different perspectives. And one of the other things I learned was that we share common goals. And I think that's something that's going to come up today when we're talking about this. At the same time, and Haner sort of touched upon this, because of the way that prevention and recovery are funded, there's some silos that exist. And there's some reasons why prevention and recovery do not connect more. Even from a state government or a federal government, you know, project officers that oversee recovery programs for the federal government and even the state government are not the same people who are overseeing programs on the prevention side. And sometimes prevention services exist in departments of public health where recovery services exist in departments of mental health. And their histories are slightly different as well, and they rest in slightly different fields. And so we need to know that there are distinct sets of services and that we can't sort of mix funding because those silos exist, right? There's money that goes to recovery and there's money that goes to prevention. The other part is we're both sort of part of this larger behavioral health family. We're under this larger umbrella, and there's a lot that we have in common. And I think most importantly is we also both address issues of race and health inequity, and that this is a really important feature. And as we continue to talk, and I think one of the other things we'll talk about is both look at the conditions in which people are living and working. And so both are very interested in addressing those issues. All right. So this is the definition of behavioral health. It is a state of mental, emotional being and or choices and actions that affect wellness. And so one of the things I'm going to ask, and I know we have a lot of people on the line, but one of the things I'm going to ask is there anything that stands out to people in this definition? What kind of stands out to you as you look at this definition? Is there anything that kind of jumps out at you? And we'll give people a minute. Choices. Yeah, interesting. Yep, a lot of people thought choices. There's choices involved, choices and actions. Exactly. Indicated choices. Yep, and the state of, so it's a state of mental, emotional being, right? And a state can change. I also think it's person-centered. That's very interesting too. That we all need to be more holistic with a goal. Yeah, the goal of wellness, which is really interesting, which really connotes a holistic approach and actions. It also, a state of mental health also means it can change and it can ebb and flow. It's not, it's not rigid. So I think that's great. Empowerment of individuals. These are great. And so what we find is this is a broad enough definition that we find that both prevention and recovery can fit within this. And as we're going through today, I think that what you're going to find is some of these mental, emotional states of being and the idea of wellness is really going to come up as themes. And one of the things we can ask are, do we think that, recovery and prevention fit under behavioral health? So that's great. And I think I'm going to turn it over, Haner, to you for this one.
Thank you, Carol. So some of you might have seen this depiction in the past, and it's really to begin or continue this conversation around issues of disparities and inequities, and how do we build equity. And so I'm going to ask you for a moment to focus on the far left of your screen where it says equality, and to think about, what do you see, what do you say, what do you think, what do you push back on when you see that depiction of equality, the depiction of equality, right? And again, people are already chiming in, they've seen this before. And in equality, we have three people of different sizes, right? And they're trying to watch the ball game. And so, think critically about what that looks like. And not all three can see over the fence, obviously. And, but they all have the same boxes, correct? The other thing that always strikes me is that these folks are trying to look at the game from the outside, right? And one of the questions that I ask people in live training throughout the country is, do you think equality exists? Do you think equality exists? And a lot of people say yes, and I see some people saying no. The reality is that equality exists only in the minds of people with power and privilege, people who have experienced discrimination, exclusion based on race, ethnicity, language, based on sexual orientation, gender. People who have experienced those disparities, for the most part, will say, no, it doesn't exist. And so I bring you now to the far right where it says reality. And I want you to also think critically about what you see, what you say, what do you think of, what do you push back on when you see reality. And for some people, this is the first time seeing this. Again, thank you for sharing that in the chat. And for some of you, you've seen this before. This smallest person here is not trying to dig a hole to get underneath the fence to watch the game. This depiction is of a person who is in a ditch. And some people have been relegated to the ditch, and entire communities even before they're born, because there's such a thing as generational poverty. And there are policies and procedures that keep people in that space and place. And what I usually tell people is, think about the rhetoric that we use in relationship to this issue. Many times people say, oh, pull yourself up by the bootstraps and rugged individualism. And if you work hard enough, you're going to get to where you want to go, and you can be whatever you want to be. And that is a huge crock of shit, forgive my language, we're adults here, right? Because I know people who work 3 and 4 jobs, they work harder than I do, and they will never make in a week what I make in a day because of structures that are in place. It doesn't mean that there aren't people who have come out of that ditch, but we need to be careful with that. If it was just about hard work, every single woman in Africa would be a multi-billionaire. So it's not just about hard work, and some people are relegated to that ditch. When we see the person in the middle, what do you see? You see that nothing has changed for that person. One box, enough to be able to see over the fence. And then when you see the person that didn't need a box to begin with now has 7 boxes, the tallest person there. And, I want to draw attention to power and privilege. And for the most part, when many people see this, they think about people with a lot of resources. But every single person in this training has power and privilege. We have credentials, we have a job, we're being paid, we are using technologies, we have a home to live in, we have an income, we have all of those things, maybe not at the same level, but we too have power and privilege. In reality, in society, we have a very few number of people, primarily white men, who have a lot of power and privilege in this country. Billionaires, but not everyone is out for themselves. 2016 tax reform, one white guy, billionaire, said, I don't need a tax break. My secretary needs a tax break because she pays more taxes percentage-wise than I do. You know who that person was? That person was Warren Buffett, in the news again recently around issues of giving away half of his fortune, right? And so think about that, because there are people who use their power and privilege to help other people, right? But that is the reality in the society in which we live in. And then I want to bring you to the center of this depiction, to equity and thinking about equity. What do you see? What do you say? What do you push back on? What do you think of when you see equity? And for the most part, people say, oh, now they're happy. Fists are up in the air, hands are up in the air, right? Now the person in the middle has still the same box, but is looking at the smallest person. The smallest person has 2 boxes, and the tallest person doesn't have a box at all. It appears, right, that looks like equity for some people, right? They would think about, wow, that's awesome. But think about this. If you ask these 3 individuals or anyone in society, do they want handouts, or do they want to participate fully and be treated with dignity and respect? The problem here is defense, good people. That is the problem. And the defense represents policies and procedures that keep people out of full participation in their health, in the economy, and everything else. If you ask these 3 people, they want to be sitting in the bleachers with everybody else, paying the $12 for the beer and the $13 for the stinky hot dog, and to be able to participate fully in society, right? So let us not be fooled by the boxes, even though we are called upon to deal with boxes, right? Because we have the ability to get people into care, to get people into treatment, to get people prevention resources, those sorts of things, and we do that. But if we just do that, we will be chasing our tails for a very long time. We need to deal with prevention, and prevention includes policies and procedures. Recovery also includes policies and procedures that enable people to participate fully in their recovery and in society. So that's this slide. I'm going to give it back to Carol. And thank you for all
That's
of
great.
your wonderful comments in the chat, and your jokes around the stinky hot dog thing that I just said. Thank you.
That's great. And Haner, what I love what you said about the fact that prevention and recovery are about policies and about change. And I think what that makes me think of is the fact that doing prevention work or doing recovery work provides an opportunity to look at some of these issues, to see if some of these issues can be addressed. And in fact, you can't do prevention and recovery really well unless you have shine a light on these issues, you're aware of them, and you understand that this is an opportunity to address some of this. And I don't know if you'd agree with that or not, but that's what occurred to me in the way that you described it. It's great.
Mm-hmm.
So we're gonna move on. So this is beginning the conversation. And again, I think that, whenever any sort of 2 fields, whether it's, physical health and behavioral health, or, it's recovery or prevention, we need some place to sort of begin the conversation. And I was part of a program which was going around the country, and it was looking at, why is it that prevention, treatment, recovery, and physical health, what's getting in the way of collaboration? And there were these discussion groups done all over the country. And some of the themes that came out were so obvious that we know, right? One was language was really huge. When we're speaking, do we understand what each other is meaning by the language that we're using? And another was incentive. Do we have the incentive to want to work together? But underlying a lot of it too was those opportunities to have conversations and begin and build relationships. And that's at the heart of collaboration, is that building relationships. And you need to begin somewhere. So a part of this that we're hoping will happen is this is our all beginning to have a conversation and a dialogue. And part of learning is being able to feel comfortable asking questions. When I was designing a training with prevention and recovery, and I was working with people on the recovery side, I needed to learn a lot. I had to ask a lot of questions. I had to look at my own assumptions about what I thought about things and the way that I looked at it, and I had to change my orientation a little bit. And so those conversations became key. So I think underlying this training, what we're hoping is a bit of it, although there is presentation, is going to be sort of a giant conversation, and we're hoping that you will feel comfortable asking the questions that come up for you as we go along, and making comments along the way, which you've already done so brilliantly. Whoops. Okay, so where I want to start is I just want to get a sense of one of the things that's interesting is when we use the word prevention, what words come to your mind? And it may be different depending on where you're sitting. So when you hear the word prevention, what comes to your mind? What do you think about? We'll give people sobriety, youth, community-based education, forward thinking, coalitions before, primary, secondary, tertiary, policy, action before problem, resiliency, wellness, avoidance, health, community resiliency, roots, refusal skills, harm reduction, ACEs, adverse childhood experiences, upstream. This is great. These are like a lot of the things we're going to talk about. Partnerships and networking, poverty, starting, risk factors, resources available for support, education about addiction, recovery, stopping something before it begins, capacity, fear of failure, that's interesting, engaging, early intervention, proactive, harm reduction, accessibility, intervention via education, self-care, harm reduction, education and skills, the SPIF, the Strategic Prevention Framework, for those of you who may not be as familiar with it, bonding, that's great. So we're gonna be sure to choose, starting to teach healthy choices. Okay, so we're gonna stop with that, and thank you for all of your responses. That was just fantastic. You sort of, in a very short matter of time, captured a lot of what we're gonna be talking about. So next what we're gonna bring up is, what do you think about when you hear the word recovery? So what is it that you think about with the words that describe recovery? So what comes to your mind with that? Wellness, strength, freedom, clean and sober, hope, wellness, moving, new beginnings, journey, change, rebirth, return to, harm reduction, hope, community, resiliency, wellness, honesty with yourself, self-compassion, life roadmap, living new life, purpose, baby steps, strength, a lifelong journey, community, strength, self-empowerment, wellness and growth, rediscovery, empowerment, perpetual surrender, solid foundation, self-care, struggle, healing from past hurts, privilege, love, eternal learning, continual, nonlinear, trust, intervention, God. These are great. Motivation. These are great. A life in the community. So here's my question. Do you see any similarities between the words of prevention and the words of recovery? Are there any sort of words that stood out? Resiliency, yep, I noticed that too. Hardest thing you'll ever do, best, wellness, hope, exactly. Even the part about it being hard for me, you know, sometimes being in the prevention world, prevention can be a slow process and it can be hard. It can be a different kind of hard, survival, all of these, right? And so this is sort of beginning our conversation, caring, awareness, all of these. Harm reduction, yes, and harm reduction came up in recovery and it came up in prevention as well. Empowerment, I think that's true. You can, somebody individually can be empowered, and then you can also have somebody empowered both in a community, a family, a group of people can be empowered. So that's great. Thank you so much for sharing. I feel very invigorated from this exercise.
Carol,
The concepts are the same.
Carol,
Yep.
I would also like to chime in here. I think it's awesome
Yeah,
that people
please.
have put all of these up here. I would add the multiple pathways of recovery to this conversation,
Yes.
right? That there is no one way of doing things, and people do employ multiple pathways that work for them, and isn't that great to see as well?
I think that's great. And I think the same too is in prevention. As we know, we can't really make change without multiple ways of doing it, right? You can't, you have to have multiple ways of doing it. So I think that's fantastic.
In public health,
all right.
public health terminology, multiple strategies over multiple domains, right?
Exactly.
Mhm.
Exactly. My favorite multiple threes, multiple population settings, right? Yep,
Mhm.
that's great. All right. So here's what we're going to be exploring today. So we're going to be exploring, what are we preventing and what are we recovering from? Now, and Haner can tell me if I'm right about this. One of the things that can happen, and this is my understanding from people in recovery, so I don't mean to speak for someone, but this is that sometimes when you say, what are you preventing? For somebody in recovery, it can feel like, why are you preventing me? Why are you preventing my experience, right? So there's a little bit of to be careful around when we're using some of the language. What's the goal of prevention and what's the goal of recovery? Where does it take place? And this I find really, really interesting. Where are the environments that it takes place in? And what are the frameworks and models that we use? And what are the crossovers of those models that get used? And I think those are really, really interesting. I had the experience of many years ago, I think I was in the state of Alabama. I think I was in Tuscaloosa, Alabama, which is a lovely place to go if you ever get the chance. And I was doing a training on sort of a prevention fundamentals. And I had like 3 or 4 or 5 people in the class that were in the recovery field. And they came up to me and they said, this is so amazingly helpful for my work. It's kind of the first time that I realized how close prevention and recovery were and some of the commonalities that they had in the work that people do. There was just, and what they brought to the table was just so helpful for the people who were learning about prevention. So there's a lot of similarities there. Okay, so I'm going to turn it over. We're going to focus on prevention, but before I do, Chris has something she wants to join in with.
Yeah, thanks, Carol. I just wanted to recognize again, I know we touched on it in the beginning, but that the Peer Recovery Center of Excellence is partnering with SAMHSA's Prevention Technology Transfer Center Network and the Great Lakes Prevention Technology Transfer Center on this series, and that the purpose of the PTTC network is to improve implementation and delivery of effective substance misuse prevention interventions and provide training and technical assistance services to the substance misuse prevention field. And I know you can't click on the links in the webinar, but I did put the links to both the PTTC network and also the Great Lakes PTTC on this slide. So we're just really proud and happy to have such great partners in delivering this information. Thank you, Van.
Well, and I think, Chris, I think the other part too is that in delivering it, you're sort of role modeling, right? It's recovery working with prevention and breaking down silos, like to deliver the training, which is great. Okay, so we're gonna move to a focus on prevention. For some of you who are been in the prevention field, this is going to seem really familiar to you. You're going to say, I know this, I could teach this. Which is great. We cover the information because not everybody is exposed to it, and we want to make sure everybody gets on the same page with the knowledge of prevention and the knowledge of recovery. I definitely welcome people to either, if you have questions or if you want to just add things into the chat from your own experiences, or you want to add a point to it, please feel free to do so. This is a shared learning experience. So this is what we call the Institute of Medicine Community of Care. So some of you may have seen it, some of you may have not have seen it. So it was first designed by the Institute of Medicine in about 1994, and it was originally called the Mental Health Intervention Spectrum. And it was really about showing people the continuum of care across mental health related services. And then in about 2009, and so this really in the beginning, it was really in reference to the prevention and treatment. 2009, they added promotion. Now, what's interesting is this is a model that prevention tends to use when it's trying to understand where does prevention fit in relationship to the other parts of behavioral health, in relationship to treatment and maintenance and recovery. And this really helps to sort of gain an understanding of that. So it's helpful on that front. I did a training a couple of years ago, which was the intersection of prevention, treatment, and recovery. And what I learned, to my surprise, is this model is not really used as much on the treatment nor the recovery side. It is really a model that preventionists tend to use. And so it's helpful from that point. And we're really going to focus on sort of the prevention and promotion side. But there are some things lacking in this model. And I'm going to have Haner talk to you about that from the recovery perspective.
Thank you, Carol. So yeah, when many people have seen this model, they go, wow, yeah, this is a medical model, clinical model that doesn't really take several things into consideration, right? So we understand the deficiency here, and let me just say a few more things about that. Number one, many of us are familiar with prevention, intervention, treatment, and recovery supports as the public health continuum, right? Prevention, intervention, treatment, and recovery supports. And many of us have said even that model is problematic. Why? Because you see the treatment piece here. We know that there are multiple pathways of recovery, to bring that up again. And what really belongs here is the multiple pathways of recovery. And treatment is a pathway of recovery for many people, but it's not the only pathway, you see? And so you can enter into recovery and into a pathway of recovery, even from the indicated portion of prevention, and not just because you went to treatment and that's where you initiate recovery processes, right? And so, you know, we'll talk more a little bit later on about what those pathways look like and what they are, that sort of thing. And we also need to understand the dynamic of people who experience reoccurrence, what some people call relapse or setbacks or slips, and those sorts of things, right? More importantly, we need to understand not to be punitive towards people, right? Our field has a history of being punitive to people who have reoccurrences or exhibit signs and symptoms of their disease, if I can put it that way, right? So when we see this model, it's helpful to understand what's going on in the field and how people think about this stuff. But for those of us in the recovery community, as well as people who work in prevention, we need to make sure that these models are representative of what's happening on the ground and the perspectives, which are many, from people who work in this space and place.
That's great, Haner. I also think if we were going to change this, we would sort of have the recovery go all the way into the indicated population. And one of the statistics that I find so fascinating is that, you know, 70% of people, and I could be wrong here, so you tell me if I am, but 70% of people who go into recovery never touch treatment. Treatment only really reaches about 30% of the people. That's a lot of people who are going directly into recovery through from sort of being in a, and we're going to talk about what indicated is. The other thing I really love is I have a colleague, and she did a version of this model where it's a whole circle. Because the truth about it is, for people who are in long-term recovery, you know, and even people who are in treatment and maintenance, you're still part of promotion. And if you look at this model, you'll see at the bottom, and we're going to talk about promotion, it goes all the way through. And so people who are in recovery are also people who are part of creating a whole well community and are a part of that. And so the model is helpful, but we could also redesign the model to be a little bit more accurate. So I think that's great. So what I want to do is I want to dive a little bit deeper into the different, and let me just see if anybody on the line wants to add anything. Let's see, I have always viewed treatment sections of the continuum, as a necessary part of the process wherein individuals gain and regain the tools needed to help. A lot comes from themselves that personally came in via the courts. All right, these are great. Excellent. So I'm going to continue to go back and forth between the comments because, as I said, we're learners and teachers, all of us. Okay, so we're going to move on, and I'm going to start with these sections, which is this is sort of where we're going to focus on prevention. Now, one of the interesting things about prevention is, and I have a lot, of course, I work in prevention. I have a lot of conversations with people. Depending on where you're sitting, you know, on this diagram, influences how you view prevention, right? So if I'm in treatment and I'm doing medicated assisted treatment, I'm thinking I'm doing prevention, and I am doing prevention, right? If I may see prevention as working with people who are at risk for overdose and making sure that there's Narcan available and that they don't overdose. And that is part of prevention. And then other people see prevention and they think, wait, I think of prevention being working with kids in schools and classrooms and working with parents. And that's also part of prevention. And so I think the interesting thing about prevention, and I find very hard to convey to people, is the spectrum of how large prevention is and the different types of audiences that prevention works with. And it's not just one. Even within the prevention field, you know, people who may be working on one side on indicated populations may know less about people who are working in universal, or they may not. But I think it's really important, this idea that it is sort of a large levels that is included within the prevention field. And we want to make sure that we have sort of that comprehensive understanding of what prevention is. Okay, so that brings us to health promotion. So health promotion, you know, this process of enabling people to increase control, I think at the heart of health promotion is the idea of making decisions towards wellness, right? It's about making decisions that I am going to embrace some type of wellness. And when we talk about wellness, wellness can be physical, it can be emotional, it can be social, it can be spiritual. And so embracing wellness means that I am just making a decision or moving towards something that makes me feel well and whole in some way. And I don't have to do all of my wellness all the same time. I may make a decision around seeing more people because I feel isolated, but I'm not really ready to embrace more physical exercise that I feel like I need as well. And so wellness is about adding value added into one's life in some shape or form. And it also occurs at different levels. So in about 2018, the Institute of Medicine added sort of subsections of promotion, and they added individual, family, and community. And all that really means is that in each of those levels, wellness or decisions or supporting decisions is able to happen. So for example, as an individual, I may decide, as I said, it's been COVID, I've been really isolated. I want to make sure that I see friends and get out and put that in my schedule. I want to make sure that I do that. Or my finances are a mess and I want to have some financial help, and I'm finally going to go sit down and talk to somebody because I need to do something about it. So that's an individual. I make an individual decisions, but families can also make decisions towards wellness. It may be that a family decides, you know what, we want to have dinner 3 times a week together without any electronic devices whatsoever. Or once a week, we want to go, you know, a husband and wife can say, you know what, we want to, or a child and a adult or parent can say, you know what, once a week we want time together. We're going to go for a walk. So adding in those opportunities for bonding within the family towards wellness is something that you can see in the family unit. And then in community,
Oh, Carol, you muted yourself. Carol, you muted yourself. We still can't hear you. Sorry for the pause. So Carol, you're muted on screen, and I believe your other device is muted as well.
Yeah, Chris, I do not have the power to unmute her. I can only ask her to unmute.
Sure. Okay, you're unmuted on screen now, and then I think your phone needs to get unmuted. Thank you for your patience to the audience as we
Yeah.
just pause to deal with this technical issue.
No, you're still muted, Carol. Is there just a *6 on your phone or unmute button? Hmm. We're not getting anything. Chris, do you think we should ask Carol to hang up and dial back in?
Yeah, I think that would be appropriate. I think she's typing something.
Yeah. We'll get this straightened out, everyone.
Carol just said sorry and give me a minute. Why don't we do this? And we had a break planned for a little bit later, but we are at 9:50. So let's go ahead and take our 7-minute break right now. We'll come back at 9:57 Central, 10:57 Eastern,
Great idea.
7:57 Pacific. So we'll be back. And do you want to pause the recording, Cindy, and then we'll
Yeah, I will. And I just want to tell Carol that it looks like her phone is unmuted as well. So I wanted her to say something, but I'm going to pause the recording. See you back here soon, everyone. Wow. No.
We're on health promotion.
Excellent. Excellent. Well, listen, thanks everybody. I'm glad you got a break. I'm so sorry my phone cut out. But thanks to Chris's quick thinking, we were able to rectify the situation. So we were in the process of talking about health promotion, and I think where we left off was in reference to community level health promotion, which is really around supporting people's ability to make decisions around wellness. And this is really where health and equity comes in, right? If I don't have access to fresh fruits and vegetables, how am I supposed to make healthy choices around eating healthy foods if most of the food I have access to in my neighborhood is processed? I can't. Or if I'm living in a space and everything is blacktop and there is no place for people to gather or for people to walk, that's not creating a condition in which I can then make healthier choices. And so a lot of what happens with the community is around, having farmers markets and making sure there are open green spaces where people can meet, and not just open green spaces like for wealthy people, but making it sure for like wherever people are, that people have the ability to walk and meet and see each other, and they have those opportunities. And so that promotes wellness, and that's on a community level. And what's interesting is when we continue to talk about prevention and recovery as well, what you'll find is this idea of supporting conditions, whether it's around people making healthy choices, or it's around people making healthy choices within their own recovery. The conditions that we live in can either not support or can support that. And I think one of the things that prevention and recovery have in common is we both work on that. So we're going to move on. So prevention. So what's interesting about prevention is that it occurs prior to the onset. So before I develop or somebody may develop a substance misuse problem, there are interventions and strategies that can be used in order to, and we're going to talk about this more, reduce factors that may put them at risk and increase factors that may protect them. But it also reduces harm for people who may be experimenting or experiencing substance misuse, which means that if I'm a person and I'm using prescription medication, prevention will reduce my risk of developing or misusing prescriptions. Or if I'm misusing prescriptions, prevention will keep me and reduce my harm from perhaps overdosing. And if I overdose, prevention will help it so that I don't have a fatal overdose. Or if I have a non-fatal overdose, prevention will work to make sure that I don't then have another overdose, because having one overdose puts me at a much greater risk for having another overdose. So prevention works on both those levels. It's working on before the onset of the problem, but if I begin to misuse substances in way or use substances, it will also help to mitigate any harm. So let's use an example. So let's say I've been to a party and I've consumed too much alcohol, right? Prevention would say, I want to mitigate the harm that I'm going to do to myself and others, right? And so so my knowing, or there being a designated driver, or my knowing that I shouldn't get in the car and I should make other arrangements or call a cab, all of those things, that is mitigating the risk to myself and others of having a negative consequences due to what's happening. And so that's another level that prevention works on. So prevention is considered part of behavioral health, but it's also considered part of public health, which means there are public health related problems that prevention also addresses that are associated with substance use, like motor vehicle crashes, alcohol poisonings in colleges, those sorts of things. And so those are the sort of three areas that prevention is working on. Again, it promotes the emotional wellness, and I talked about it works on preventing complications. And then the last piece, and I've talked about this a lot, is it really creates the conditions to foster and promote wellness. So it's doing all three of those particular parts. Now I'm going to go to my chat and see if there's anything that anybody wants to add to this. I think prevention can be interventions. It really depends on what you're doing. Okay. Prevention can be, yep, with the help of others being able to turn off the negative inner voice. Even treatment can be a prevention of sorts. Yes, exactly. And an example of that actually is, so, and we're going to talk about this more, one of the risk factors for developing a substance misuse problem is a family history of substance misuse or a parent. And so if I have a parent who is in recovery, that is actually, and then I provide a prevention program for the youth, then I'm actually engaging in a prevention approach for that population. And you can see the connection between the recovery and the prevention. Okay, Haner, do you want to add anything to this, given that you are as schooled in prevention as you are in recovery?
Just thinking that some people are working on prevention, but they don't know it, right? The example that you just gave, a risk factor for children and kids is to have a parent who uses substances. So if you're working with a parent who uses substances directly and indirectly, you are preventing, right?
Yes.
Risk factor, reducing that risk factor for young people and in that family. And so some people don't see themselves as working on prevention, but the work that they do impacts prevention. Again, if we think outside of the box, we can see how we can help to break down silos in terms of thinking. And I too am monitoring the chat. And I see that some people are saying, well, that's not quite prevention, or that's prevention for this and not prevention for that. And I get that, because there's a lot of conversation that people have around what is correct and what isn't correct in terms of prevention. Same thing happens around intervention, treatment, and recovery supports in terms of disagreements. And those disagreements are fine. The reality is that we should be working more in coordination with one another, right? To help develop healthy communities, healthy individuals, healthy families, therefore a healthy society, right? This whole focus on, if you do that, it's not really this or it's not really that. In my personal and professional view, really doesn't help in terms of forming collaborations that are long lasting.
That is so well said. That is so well said. So here's the thing too. So, one of the things that you saw in that continuum is this idea of universal, selective, and indicated. And you may or may not be familiar with it, but universal strategies are those strategies that impact everyone. So the easiest example to understand, I think, comes from tobacco control and smoking and reducing smoking rates that then would contribute to reducing heart disease and cancer in this country. And, for the longest time, we really weren't able to do universal strategies. It was just, there was a lot of political will not to do it. And it really wasn't until the attorney generals sued tobacco companies that there then became a lot of revenue to be able to do it, and there became the political will. And you saw policy change. You saw strategies and policies that said, I can't smoke everywhere because I may harm somebody else's health. And so we had, where I'm going to be careful about where I put cigarettes in the grocery store, because I know that kids start smoking. About 90% of kids start smoking before people start smoking before the age of 18. And in order to start smoking, I got to get them, which means that if they're really easy to get in the store and I pilfer them, it's easier for me to start. So I'm going to do a strategy, which means I'm going to make it hard for all kids to make it difficult for them to have that first cigarette. Those are universal strategies. And I think one of the things that is different, I think, from prevention to recovery is prevention is thinking on this population level. Yes, we want to change and we want to build resiliency in 30 kids in a classroom. But what we also want to do is we also want to decrease kids in 9th grade, and we want to reduce their rates of substance misuse or binge drinking. And I want to move the entire population of those kids. And to do that, I need to work in all 3 of these levels. And so prevention is always thinking about population as well as individuals and families. So with universal, it targets the whole population, and we think about public policy campaigns, a curriculum that happens across an entire 9th grade, let's say. One of the things I live in Salem, Massachusetts, and I have this local theater that unfortunately went out of business. But one of the things I love is all the local health-related people would put in campaigns, and they would have them in the local movie theater. And they would be really educational, and they would teach me different things that I didn't know, and they would promote me to make health and wellness decisions. And so those are the social media kind of things about the healthy choices that we can make. So that's the universal. And the most amount of people, the reason it's the biggest part of the triangle, is it impacts the most amount of people. And this kind of goes to what Haner is talking about, that prevention has to be successful, prevention kind of has to involve everybody. You need you need the entire population. You need the community to have input. The problem has to be owned by everyone. And so in some respects, people don't know they're a part of prevention. You could say that kids having access to going in Salem, we have Park and Rec, and they allow all the neighborhood kids, there's a lot of parks, to go, and they have Park and Rec staff that work with the kids, which means parents can go be working. They know that their kids are safe and they're working with healthy teens. And so that can be preventative. All right, so selective. So this is what we were talking about when we gave the example that if I am working with a parent who is in recovery, or let's say I'm working with a youth and the youth's parent is using substances or misusing substances, that puts me more at risk. So selective actually focuses on those people who may be more at risk than other people. Another example that I like a lot too is people mention in the chat this idea of adverse childhood experiences, which was a study that was done that says that there are certain traumatic events that can happen in childhood, and the more of these traumatic events, the more it's going to impact me. Working with kids who experience adverse experiences, who are more at risk for substance misuse, and doing specific interventions with them would be considered something that is working on kids at risk. Another one that's quite popular is sometimes kids get arrested for nonviolent offenses. So kids get arrested for, you know, drinking in the park or something else. And so in some communities, they have these kids, and rather than, you know, penalizing them, they actually do sort of prevention education with them, and that would be considered another population that's at risk. And then the last, which is the smallest, is the indicated population. But small does not mean that it's not essential, right? And this is really targeting people who misuse substances. And I would say in the last 10 years, the prevention field was much more accustomed to targeting selective and universal strategies, right? That was our comfort zone. And with the advent of opiate overdose and opiate misuse and all the impact it was happening, preventionists needed to learn how to, as we say, go downstream. And we needed to figure out how to do those community conditions that would support, so that if somebody was going to have an overdose, they increase their likelihood that they could get Narcan. And after that, that they had support. And these are people who are not necessarily in recovery, they're not necessarily in treatment, and we need to keep them alive, and we need to be able to move them towards wellness and reduce their harm. And so prevention is, over the last 10, 15 years, has really had to become much more comfortable working with indicated populations. Indicated population is the population that's shared the most across prevention, treatment, and recovery. You know, when I do work in opiate overdose, there's a lot of recovery coaches that are working side by side, that are making recovery coach resources available. There is, you know, interventions, brief interventions that's going on in case people want to pick up the fact and let them know early that they may have substance misuse. So indicated populations is where, you know, prevention, treatment, and recovery, they all kind of all working with indicated populations. But the universal is also impacting, and they're also sort of working in communities where universal strategies are happening as well. So I'm going to see, Haner, is there anything in the chat, or do you want to add anything to that?
The chat is lively, people coming back and forth regarding how they view prevention, what informs their views of prevention. And also there are some folk who are saying that we should be very careful with the language that promotes and sustains silos, right? And so I think that what's happening in the chat and the recommendations and things that people are saying are all positive. And here's why I think that way, because we don't all think the same. And because we are coming at this, right, from different perspectives, from different ways of viewing the continuum and different ways of being trained to do this work. And when we get into these conversations that for some people might seem difficult, for me, they're important to have, because in having conversations is in which we develop agreement and partnerships across the board. So keep that stuff coming. And thank you very much for all of the comments that people are putting in the chat.
I think that's fantastic. And I think when we began this, we talked about that we're going to have a conversation. And the truth of the matter is, you know, my background is a lot in adult learning. And, you know, one of the things I always find interesting is for anybody to learn something, you have to filter it through your own experiences and your own paradigm. And you have to clarify and ask questions, and you have to be able to have that dialogue to really understand. And it's that conversation that really moves people towards moving towards understanding each other. And I think is what you said is that's not always an easy process, right? That's you know, you have to clarify. It can be uncomfortable. When I was first doing the training on prevention and recovery a couple of years ago, I remember thinking, I have to ask a really uncomfortable question. You know, I don't want to insult anybody, but I don't think I understand this. And you know, and I had to be told some things that I didn't realize and I wasn't aware of. And so I think it's great that people are having those conversations.
It also, Carol, I just want to say, this also touches on our biases and judgments, and we all have them. Whether we want to admit that or not, we all have them. And so, you know, early on in my career, when I heard harm reduction not being put that way, but being talked about by way of needle exchange or passing out needles, I was adamant against it because I thought it was condoning drug use behavior. And my prejudgments and my biases really came out, and they really hurt people because dead people don't recover. And people who are seeking recovery also get infected with HIV and hepatitis C. And who am I to say that because of my own prejudgments and biases, that people shouldn't have access to prevention strategies that help keep people safe and alive? And so we're talking about things that are controversial. And I really like what people are saying in the chat and saying the dialogue is difficult, but it's important to have. We should just have the dialogue, right, as we're having here. And I don't see anyone here saying anything that's disrespectful to anyone else. It's a part of what we do, right? These are growing pains of a system that hasn't embraced fully prevention, intervention, treatment, and recovery supports. We haven't. As a society, we haven't. And we need to struggle through these things together and learn from each other if we're going to make a difference or continue to make a difference.
Said so well. So really quickly, so I'm going to sort of summarize this continuum and what we've been talking about. So the universal and selected, the whole population and people at risk really is before the onset of the problem. You also see that promotion is wellness across the whole continuum across here. And then what we find is indicated is really before diagnosis. And all through this, what we're trying to do is we're trying to reduce risk and reduce harm. So that's a little bit about that. I want to be out. And in the universal, we're creating the conditions, which I don't know why that really appeals to me, but it does. So what I want to talk about, and people are familiar with this, right? So we have these things called risk factors, and we have these things called protective factors. And risk factors, you know, are biological. If my mother or father had a substance misuse or there's substance use disorders that run in my family, which they do on both sides, I'm more likely to develop a problem. There's family, right? There's community, poverty, and lack of community bonding, and are all risk factors. And what it means is that there's a higher likelihood of a problem. Now, when preventionists think about this, they're not thinking about this on an individual level, like this person has these risk and protective factors and this person has these individuals. Now, that's what we want. We want individuals to have less risk and we want them to have more protection, but they're really thinking about it on a population level. So when I'm looking at all the population, where do I have a lot of risk factors? And which protective factors could I build up a lot more so that I can impact this problem? And then we have protective factors, and I have a friend who used to call protective factors sort of like a warm blanket or a coat in winter, right? These are the things that lower your likelihood of developing a problem. And so, you know, on an individual level, healthy, for kids, healthy relationships with adults outside their family can be a protective factor. You know, bonding to your school and community can be a protective factor. Parents who, you know, set limits and for you can be a protective factor. And so within the community, we have both risk factors and protective factors. Now, from a historical perspective, this sounds like really obvious, but when I started in the field of prevention, it used to be people said, here's the problem, here's the strategy. And people would move to the problem, and then people would just say, I think I know the strategy. And when the advent, and the risk and protective factors in the field of prevention is probably only about 30 or 40 years old. With the advent of risk or protective factors, people could say, you know what? A risk or protective factor is a lever. And if I have a lot of this and I push that lever and I reduce risk, I'm much more likely to influence the problem, right? And if I push another level and increase protection, then that's also going to increase the likelihood that I'm not going to develop a problem. And so the risk and protective framework in prevention is really key because it really helps us zero in on those levers that are influencing the problem. And what we find is they occur sort of at an individual level, right? Biological, a family level, and a community level. And so if I'm working on, trying to embrace wellness and reduce substance misuse in my community, I have to work on all of these levels. And one organization and one school cannot do it alone. And it's why effective prevention approaches have to be community-wide. And it's what Hanera said, they have to include multiple systems at the individual, family, community level. There got to be multiple interventions because I have different risk and protective factors in all of these places. And it needs to be in multiple settings, right? I need to have it in school and I need to have it in the community. I need to have policy while I'm also having, support groups for kids who are more at risk. And that's the way I can actually get population level change, is by working on all of these levels. Questions that anybody has or any comments in the chat, Hanera?
No.
Okay.
There's a lot of comments, healthy dialogue.
Good. Okay, so when we targeting risk and protective factors, one of the areas that substance misuse prevention is very good at is we've gotten very good at looking at in the research what are really the factors that are driving the problem, what are not. And it's what we call evidence-based risk factors, right? So we want to make sure that when we're saying that something's a lever, it's like somebody studied it and said, yes, we can actually prove that that's a lever. Like when we're trying to reduce heart disease, we know that diet and exercise and smoking are levers that influence that. We want the same in risk and protective factors. So what we want to do is determine them. There are ways in which they get assessed. You can literally go into a community and you can look at the risk and protective factors and you can find out which ones are high and which ones are low. And then based on how that comes out, the community then decides to focus on the most important risk and protective factors and then develop strategies around them. So really at the heart of doing community-based prevention, it's determining this combination of risk and protective factors, and it's then developing interventions. And again, these factors are in multiple levels, and that's why I need a coalition. That's why I need, the superintendent, and I need the police chief, and I need the Latino organization in my community. I need the neighborhood groups. That's why I kind of need different parts of the community because these exist on these different levels. Okay, I want to make sure, Hanera, you have enough time. So another part, and we've talked about this, is this goes to the inequities that we saw in that beginning slide. And I really love this because imagine the conditions and risk factors. If I'm in a community and I have the shrinking tree because I've got adverse living conditions, poverty, unemployment, discrimination, poor schools, I do not have the conditions, right, that's going to allow me to be able to address those underlying conditions. Those conditions are going to impact, those themselves are risk factors unto themselves, right? And I need to address those risk factors in order to really get real change. And the other part says kind of our aspirations. This is what we want. We want adequate housing, we want access to food, clean environment, we want all of that. So in prevention, when we're also looking at risk and protective factors, we have to be looking at those underlying social determinants of health and really find out what is going on. Does everybody have access to education? Is there discrimination? What's going on in our neighborhoods? Those are important questions. Okay, and then when we want to address social determinants of health, and again, this makes sense. This kind of connects to what we were talking about prevention. We've got upstream to improve the conditions. Those are more our policies. And then we've got downstream strategies that we want to make sure meet individual needs. And again, we have to work at sort of this population level and conditions level, and we have to work at this social needs level both at the same time. And again, this is just saying if we want to change the fragmented system, we need to have policy, networks, participation, social supports, and a sense of community. And this is underlying what needs to happen when we're talking about changing community conditions. All right, I went through that last piece quick just because, Haner, I want to make sure that you have enough time for your piece.
Thank you. There is a question that was put in the chat. Is addressing food insecurity a prevention and recovery measure?
Food insecurity.
Is addressing food insecurity a prevention and recovery measure?
You know, I'm not sure. It could be. You know, it's kind of like is it theoretical, right? And yes, I would say it is. Mm-hmm. Or is a funder looking at it, and is the funder saying, is that directly contributing? And so there's two ways of looking at it. But yes, I think addressing, and this is sort of goes to the sort of building healthy communities and building healthy conditions. Mm-hmm. But whether a funder would say directly addressing poverty and food conditions, I'll pay for it with my grant, my substance misuse grant, that's a different question.
Yeah. And so most people in the chat are saying yes, or all people in the chat are saying, yes, it is, yes, it is, yes, it is. And in my center, we address food insecurity, you know, those sorts of things. I'm happy to hear that. I think of Maslow, right? Hierarchy of needs, and what we do with and for people is extremely important. And of course, if you're hungry, that's going to affect your recovery process. It's going to affect your health and wellness. It's going to affect everything else. And a lot of people don't even want to talk to us unless their belly's full. So yes, 100%. Thank you very much. Can we move forward? Because we have a few more slides that we want to do with the focus on recovery. Here, this would have been our break. We did that earlier, so we go with this focus on recovery. And once again, thank you for all of your comments. We want to begin by talking a little bit about what engagement looks like, right? And you know a great deal about this. You're on the ground, you're in communities, you know that we need to engage with people in many different ways, right? And so, you know, in many organizations, not all, and this is changing depending on the organization, there is this, you know, people call them target population. I don't like that terminology because it's not good terminology to target people. They're either focus populations or priority populations, right, that we provide services to. And then the question is, how do we engage with those populations, right? What is our responsibility to bring people in to hear from them what works best for them, as opposed to us telling them, this is what you need, this is what you want, right? And so true partnerships require that we are in community, that we're immersed in community. And most services, you come to me, you make an appointment, you come into my building, you behave a certain way, and then you see me and I'm going to be behind this desk and tell you what to do, when to do it. That is not community engagement. It is not, right? Establishing rapport with and among groups with related missions, right? So this whole idea of collaboration, no one organization can do this by themselves. We need all hands on deck. And someone said it early in the chat, it takes a village. I know people say that a great deal, but what does that look like, right? By way of we as providers, as people who work with community, working in partnership with one another. Enlisting a commitment to behavior change. Now, we know Prochaska and Di Clemente's model of behavior change, right? Stages of change, pre-contemplation, right? contemplation, preparation, action, maintenance, those sorts of things. And some people have difficulty with that model, but there are other models of understanding behavior change. And so we should understand that change in behavior is not an event, it is a process for many people. And then providing information about risk behaviors and strategies to eliminate or reduce risk. This is connected to the piece that Carol was just talking about in relationship to risk and protective factors, right? And so community engagement is extremely critical. And when we're talking about the recovery community, we know that that is a priority for SAMHSA, but that has always been a priority for those of us who work in the realm of prevention, treatment, and recovery supports, that there needs to be engagement, right? Can we go to the next slide? I'm gonna move through some of the stuff rather quickly in the interest of time, because we want to make sure that we leave enough time for questions at the end. And there are some questions that have come in that we haven't been able to address as of yet. So here's SAMHSA's definition of recovery, right? And so it's a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Now, this is a sentence, right? That can be considered a paragraph. It's very powerful. It took the people at SAMHSA a very long time to come up with this because they engaged people from the community in this definition. And I remember those conversations vividly. Strikes out to me is living a self-directed life and striving to reach their full potential. That is relative to who the individual is, right? The self-directed life piece comes to this issue of power, right? And choice, right? How do we put choices in front of people and enable them to make healthy choices for themselves without us imposing on them? And then some of the 4 domains are health, right? Overcoming and managing one's diseases, physical and emotional well-being, thinking about home, a recovery conducive and safe place to live. Think about what that looks like now in the country when we have a housing crisis, particularly for poor people. And if we add the fact that many of our folks are involved, have been involved in mass incarceration and the criminal justice system, how difficult does it get for people to access a recovery conducive place to live that is safe and in the community? Purpose. We all have purpose. You woke up this morning and you said, this is what I'm going to do today, and this is how this helps me. This field doesn't pay a lot of money, and we come to it with purpose. Well, if you've been working with people in recovery, you probably heard people say, you know, as soon as they're in recovery, many people say, I want to give back. And that starts with some people making coffee, cleaning up a meeting room, you know, things like that. And other people, they want to speak to other people. They want to be a part of the field. They want to help other people recover and those sorts of things, because those things give people purpose. It's work, employment, it's volunteerism, it's relationships with others, it's participating in family and community, right? Those sorts of things are extremely important for us to make sure that there are options for people to do that, and that we have supportive processes in place that help people with purpose. And then the final domain is community. Now, as a person in recovery, I belong to many different communities. I used to belong to the community who was actively using, right? And that is no longer with me. I used to belong to a community that was in jails and in prisons. That is no longer there. So I belong to the Puerto Rican community. I belong to a professional community. I belong to a recovery community. I belong to a recovery community that practices my social justice pathway. I belong to many, many different communities. And that, for me, has been life-saving. So, you know, we need to think about ways in which people develop communities. And those things do not happen in isolation. They happen in being in relationships with one another, in learning from one another, because I remember that what we sell as recovery, I remember this vividly. We think that recovery is awesome, right? I think so. But I remember when I went from prison to treatment, not because I wanted to, but because I wanted to get out of jail. And in that treatment facility, there was recovery being initiated. And those men in that treatment facility, they wanted to hug me. And I wanted no hugs. In prisons, hugs mean something different. They wanted me to talk about my feelings. What are you talking about? That is a foreign concept. I'm not going to talk to you about my feelings. The only feelings that I have is that I'm hungry and I don't want to be here. And I don't like many of you. You see? Yeah. Oh, the other thing is, you need to tell on other people in the facility if they're doing something wrong. If they're using drugs or talking about drugs, you need to go to the staff and tell on them. That is called being a rat. And I wasn't going to be a rat, right? And so when we think about engaging with people and bringing people into recovery, let us never forget that the culture of recovery is foreign to people in need or seeking recovery, and there's going to be a clash. And we need to bring people in safely, respectfully, with a lot of education and support, and not assume that everyone wants in by way of recovery. Those are assumptions that we have. And by the way, all the things that I said that I had in my head when I was in treatment, that was inner voice, Haned. I didn't say that out loud. I was smart enough not to say those things, right? So when we think about recovery, I also think about William White and what he says about recovery. Recovery is both done and defined by the person in recovery, right? And that's a really powerful statement, because in the world of treatment has been defined and done by professionals with a lot of credentials. And this is William White shedding light on what? On giving people with lived experience their own choices and allowing them to define their own recovery. This is connected to the multiple pathways, people, right? This is connected to that piece, right? So for some people, right, what is appropriate for them might not be appropriate for someone else, right? Can we go to the next slide? William White is essential for us to understand. He's a leading researcher in the country. I recommend that you go to williamwhitepapers.com. And by the way, the Multiple Pathways of Recovery Conference is coming up in Florida in October, towards the end of October. Go to the Connecticut Community for Addiction Recovery, CCAR. In their website, you'll see more information. So recovery is also connected to what? To wellness, right? Recovery is wellness. We've talked about wellness. Carol has taken us to many aspects of wellness, right? We know that recovery is contagious. William White writes a great deal about this, and others, right? And people practice it, right? It's contagious. When you are around other people who practice recovery, you learn from that and you are attracted to that, even though some people are scared of it as well. Remember what I said earlier, right? Particularly in early recovery, people might not embrace all of the concepts, but it is contagious. It differs from person to person. Going back to the multiple pathways of recovery here, right? It differs from person to person. Almost, I would say, not even almost always involves connectedness. No one gets better in isolation. No one gets better in isolation. We all have the need to be connected to other people, right? In order to get better. Whether you're in recovery or not, that applies, right? But in recovery, it very much applies. And it requires choice, this ability for people to choose what they want to do. And so I remember vividly when people would approach me and I was actively using substances, and people would say, oh, you need to get better, you need to do this, you need to do that. And I said, get the hell away from me. I just want to do drugs. That's my choice. I have the choice to do that. And I'm not bothering you. I didn't ask you for any money. I do what I do and I do that, right? And so, the people would just walk away until some people came up to me and said that, and I came with my response, leave me alone. And they said, well, we have some information that might help you in the future, or we have some needles and we want to prevent you from getting HIV. And that's sort of like, okay, that makes sense. Give me that, but leave me alone. You see? And so it requires choice, but it requires that we look inward and we respect choice. And we respect people's pathway, whatever it is that they decide to do, right? For themselves, for their families, and for their communities. That doesn't mean that we don't hold ourselves and people accountable. Because a lot of people hear me talk and they say, what about accountability? There are 23 million people in the US who identify as being in recovery, and 100% of them took personal responsibility and are accountable to themselves and to communities, right? And so we can do both. We can do many things at the same time. So think about recovery as being contagious, right? This piece. As a matter of fact, I truly believe that what is happening now in the country has been driven by recovery movements on the ground. I know that there's a lot of people who want to get in front of things and say, that's because of what I did, without giving credit to where credit is due. People on the ground doing the work, grassroots organization, people like you, more importantly, people in recovery, because there is a recovery movement in this country. The reason why we have thousands of people being trained as recovery coaches with lived experience is because of the recognition of the power of people in recovery. It is because of that, right? Someone just put up, thank you, Chris, for putting up the multiple pathways of recovery conference, the multiple pathways of recovery conference to come up in August. And by the way, if you've never heard William White speak in person, go, because he's going to be there. In terms of things to keep in mind, right? This is the piece that Carol Oliver was talking about earlier, and it's connected to the multiple pathways of recovery. Most of the funding, by the way, in the history of this country around substance use or substance misuse or substance use disorders, however it is that you want to call that addiction, I know many people call it in many different ways, has gone to treatment. Does everyone need treatment? No. Does everyone need prevention? Yes. Is prevention underfunded? Yes. Now we're getting to the point where putting money into recovery supports, but we're not quite there yet. And that's why it's a flawed system. Can you go to the previous slide? So not everyone needs treatment. And people who work in treatment get upset when they hear this. And you see the data here, right? 75% of those who meet the criteria for alcohol use disorder, right, resolve that disorder without treatment or mutual aid. And some people are like, well, that's impossible. It is possible, and we have data to prove that. As a matter of fact, William White says that we fill libraries with research on people with needs for acute care. And we can't fill one bookcase in people in long-term recovery. 23 million people and counting in the country identify as being in recovery. Not everyone did it in the same way, right? And so let's go to the next slide. So think about that, right? Because we're talking about what? We're talking again, we're coming back to the multiple pathways of recovery. And so in the principles of recovery management, we emphasize what? Resilience, recovery processes, right? Grounded in strength. That's why we talked earlier on and said we need to be strength-based. We need to change the way that we talk about people and the way that we talk to people to a language that is more strength-based. I've seen in the chat multiple times when people talking about substance abuse. Really? We're talking about a substance use disorder or substance misuse. But this word abuser, even SAMHSA has it in their title, the Substance Abuse and Mental Health Services Administration, right? But we go around calling people frequent flyers. That comes from our field. See, we like to look outward and point fingers. Oh, those people over there don't understand us. Frequent flyers comes from within the field of treatment, calling people frequent flyers, calling people manipulators, liars, right? Calling people all of those things, while we were the people who took money and a salary and a title that said we're going to treat people with substance use disorders. And as soon as people exhibit signs and symptoms of their disease, we get bent out of shape and we get put a form in front of them. You sign this that said you will not do this, this, and this, and this, and this. And now we need to kick you out and you need to start all over again. Isn't that the epitome of being punitive? We need to come back to recognizing resiliency, and that everyone has resiliency and that everyone has power and strength. Even people who have lived on the street experiencing homelessness 5, 10, 15 years, 5, 10, 15 years in prison, they survived the system that we could never survive. Well, so what makes us think that they're starting from zero, right? The recognition of the multiple pathways of recovery and styles of recovery: harm reduction, formal treatment, residential, faith-based, outpatient, holistic approaches, right? Your meditation, your yoga, your acupuncture, celebrate recovery, rational recovery, smart recovery, all of those things that people are putting into the chat, all of those things. And I will say this, because here's what I embrace. If you cannot support any one of those pathways, do not be an obstructionist, get out of the way and let someone else be supportive to that. We need to take a page from the people who run restaurants in this country and all over the world. When you get to a restaurant, what do? They sit you down, they give you some water, and they give you a menu, and they ask you, what do you want? They don't come in and tell us, you're having hot dogs, whether you like it or not. And the only choice that you have is to have ketchup, relish, or mustard. The multiple pathways are important, people. We need to allow for people to decide what's best for them and stop it with this primary question, do you have insurance? Because I think you belong here, but do you have insurance? If you don't, then you don't belong here, right? Those sorts of things. Empowerment of individuals and families. That is what recovery is all about. Giving people power, getting out of the way so people can take power, you see? And to this piece on being, our approach needs to be grounded in cultural humility and cultural intelligence. We are moving away, I am glad, from this whole notion of cultural intelligence, of cultural competency. Competency denotes that I know everything there is to know. If I am to engage with people, I need to approach it with, I don't know everything there is to know. I am a lifelong learner, and you're teaching me as much as I'm teaching you, or even more, right? We need, again, collaborations with communities that have been disproportionately impacted. You see, this system from prevention, intervention, treatment, and recovery supports has been built primarily for white heterosexual males. And if you feel uncomfortable about that statement, good. Good, because imagine the people who are dying. Imagine the disproportionate people number who have died already. There's 87,000 people who died of an opioid overdose, the longest in a 12-month period, right? The largest number in a 12-month period. Talk to those families and see how uncomfortable they feel, right? Around those very issues. And a disproportionate number of them are Black, African American, Native American, and Latino folks. We need to understand what the challenges are. And collaborations with the recovery community can help us understand that. But it needs to be the true recovery community and not just a selected few people. And then we need to have a commitment to best practices, promising practices, and evidence-based models with a caveat there, right? Some models were developed with some communities that might not work with other communities. And so we need an emphasis on helping other communities develop evidence-based models that work for them as well. Can we go to the next slide? If you haven't noticed, I talk a lot and I talk quickly. So recovery capital, right? This piece on recovery capital. It's internal and external assets required to prevent problems and initiate and sustain long-term recovery, or recovery in general, right? And so what does that look like for people in terms of internal as well as internal recovery capital? Again, I'm going to push you, if you haven't done so already, to look at William White and other folk who are writing about recovery capital and what that looks like. And then what is our role to support the development of recovery capital, right? To support the next slide, to support the development of recovery capital. And so the types of recovery capital can be found, should be found at the personal, family, and community level. The question is, we as providers, how do we help people gain recovery capital? And how do we help communities and families develop recovery capital, right? That's information that we provide to people, but it's also recognizing that people bring capital with them. Their ability to resolve problems, their ability to decide between right and wrong, their ability to make choices for themselves, right, internally, their resiliency, internal recovery capital, health insurance, external, housing, external, access to and quality of care, external, right? Those sorts of things that should exist. The ability to ask for help, internal recovery capital, right? Those sorts of things. We need to wrap our heads around that and bring that into the space that we call, bring it more into the space that we call recovery, but also into the space that we call prevention, right? Because working together, we're going to move things forward for people seeking or in need of recovery. Next slide.
Oh, sorry.
Mhm. No problem. So recovery capital, risk and protective factors, right? We know that what we want to do is reduce vulnerabilities. Those are risk factors, right? And we want to increase protective factors. We've already talked about those earlier, so I won't spend a lot of time on those. And those lead to wellness. Those lead to wellness, right? And so, it's understanding those pieces, helping people to identify for themselves what the risk factors are and what do they need to reduce those risk factors, and what do they need by way of recovery capital to develop wellness. And when that happens within individuals, families, communities, then we have a system that's working better for everyone, and not just for a select few people. Not just for a select few people. Next slide. So recovery-oriented systems of care, or ROSCs, right? Again, there's a lot that has been done in this space, not in all places, right? Not in all geographical areas, but we do know a great deal. And there needs to be a better coordinated way in which providers understand issues of addiction, substance use disorders, or substance misuse. When we understand those things, we're not putting things in front of people that put them at higher risk of having a reoccurrence or symptoms of substance misuse showing up, right? And so think about that. Recently I went to the dentist, right? I had some issues and they tried to give me pain medication. Even when I told the dentist, I'm not taking opioids. Oh, but this is not going to hurt you. This is after these people have gotten information. A recovery-oriented system of care educates everybody, including business owners and everyone else, right? Here in the city in which I live, they were trying to get people to come into the restaurants, that sort of thing. Here's their plan. Outside of the restaurants, they had free wine for people. And I was saying to the people who organized it, did you not think about people in recovery? A recovery-oriented systems of care takes all of those things into account, right? It builds on strengths and resiliency of families, individuals, and that sort of thing. We are not here to save anyone. We don't save anyone's lives. We are here to provide information, resources, and support so that people can take control over their own lives, right? And in doing so, we need to recognize that communities have solutions, they have strengths, they have resiliency. In the face of disparities, hundreds of years in development on this continent and other continents, people have survived, and that comes with strength. And we need to continue to understand that. The goal with recovery-oriented systems of care is to improve health, wellness, and quality of life for everyone involved, right? But here we're talking about people who are at risk for alcohol and other drug problems, those sorts of things. So if you don't see yourself as part of a ROSC, or if you do, good. But if you don't, think about how we can bring people together and help to create those ROSCs. Next slide. Recovery systems of care and prevention, they promote leadership development, access to community strengths and needs assessments. They educate the public and raise awareness, and they advocate for policy. Right? We keep saying this is not just about individualized services. Policies drive what people do and how we do it, right? It's that sort of thing. I'm moving quickly, but I just want to leave a few minutes at the end so that we can wrap up and address some of the questions. And so can you go to the next slide? There we go. And so we started off by saying we want to touch upon the intersections between prevention and recovery approaches. And we wanted to talk about common terms used in prevention and recovery and a more holistic approach to the continuum of care. Hopefully, we have addressed all of those issues, right? And I understand that this issue is very complex. We're not going to resolve this in 2 hours, right? And for those of us who train on this, we train entire semesters or a year long at the university level, and you still can't cover everything. But here we are. I want to address one of the questions that was up top in the Q&A section earlier when someone asked, so what do you think about addiction as a disease and that concept, right? Here's what I would say to that. I believe in addiction as a disease, and I believe in that model, and I teach on that model, that sort of thing. Recently, we did a conference of faith-based people in the Boston area, and secular people came to that conference as well. We had a recovery we had a panel of people who use substances, let me correct myself, who are no longer using substances, and their pathway was faith. And 100% of them said, I'm not in recovery, and I don't believe in the disease model of addiction. And I was saved, I was delivered, right? And that's how I don't no longer use drugs. I don't go to your groups. I go to church. I practice in my faith community, that sort of thing. And you know what I did? I applauded. I said, yep. How's that working for you? And if it's working for you, it's working for you. I have no business imposing my view, right, on other people. And if they don't see it as a disease, then so what? They're doing better. They're productive members of society. They're productive members of their community. That's the way that I view that, right? There's evidence in science, right, that talks about addiction as a disease. But for me, my goal is to help people recover. That's it. And the menu of options. If your view is not of one as a disease, but another view, I'm going to get in the way of providing you support. No, I'm not going to do that. So, you know, that's my response to that question. Thank you very much for the question, by the way.
Okay.
All
So I think we
right.
have about,
Yeah,
I'm going to turn it over to you, Chris.
Yeah, we have about 4 minutes left, and we're seeing lots of great comments in the chat. I just wanted to address that Cindy has put in a couple times, and she'll drop it in the chat once more, that there is a part 2 to this session. So if you haven't registered, Cindy will put a link in the chat where you can register to part 2, where we're going to continue this conversation. And then Van was nice enough to point out as well, at the end of session 2 next week, we will be introducing a series you can sign up for of learning labs, where it's going to be in the regular Zoom format so that it's interactive. You can come on screen, you can unmute yourself, and it's really geared towards having these conversations one-to-one between the recovery and the prevention fields so that we can continue this learning. So again, Cindy will drop in the chat the link. You can always go to the Peer Recovery Center of Excellence website, peerrecoverynow.org, and register there. Otherwise, as we're wrapping up, I just love everything that's been said. Hanir stated it best in that there's just great conversation. I feel like people are leaning into their discomfort, asking really good questions. And it seems like people are really enjoying this. And thank you to Hanir and Carol for bringing this topic to us and having these discussions. It's so greatly appreciated and so greatly needed. And I learned a ton. So if
Chris, there was a question, if somebody didn't attend one, can they attend 2? And I'm assuming the answer would be yes. We're going to do a little bit of review, but you can tell me what you think.
Yeah, so we're open. The registration is open. People can jump in and learn. We will eventually share the recording of part 1, so maybe they can attend part 2 and watch part 1 later on. Lots of options there, but the second part 2 next Tuesday is open to anyone and everyone who wants to join us. And so again, we will be putting out certificates of attendance for this training, no CEUs for this training. In the coming weeks, we will put out the recording, copies of the PowerPoints, and more information about the learning labs after the end of session 2 next Tuesday. Any final words of wisdom from Carol or Hanir?
I just want to thank people for, I'm going through comments now and reading, you know, what you've said. And I just want to thank you for everything that you do on the ground, for pushing yourself and pushing others to think outside of those boxes, right? And for helping me even to think outside of my own boxes. And so I want to thank you very much. And we look forward to seeing you again very soon.
Yes, and the same, I couldn't have said it more eloquently, Hanir. So thanks everybody. This is a real honor to do this and to work with you, Hanair. It's fantastic.
And we will pull the, we're saving the chat and we'll go through the Q&A and review some of those questions, pass them along to Hanair and Carol and see if we can incorporate some responses. Some of your questions might get answered in session 2 as a preview. I know what's coming up, so I know a lot of the questions that were posed are going to be answered in session 2, but we will take a look at the chat and the Q&A section and try do our best to respond to everything. And like I said, the learning labs will be an opportunity for that deeper level of engagement. So again, thank you for spending this morning with us. We appreciate your time. It's really valuable. It's your only non-renewable resource. So I really appreciate that. I think that's it. We can wrap it up. We're right at 11.
Yes. Have a great day, everyone. Thank you so much to our amazing presenters. Bye all.